Okay, good morning, all chairman and panelists. I'm Dr. Gawin Pieanmee from Somdet Penang Chao Sirikit Hospital. A 30-year Thai woman come to see me with a history of 2 weeks ago. She fell down on her left hand in the toilet. She got pain and deformity, and she was underwent operated at the province hospital 1 day after injury. Physical examination, she was splinted on a long arm slab, decreased sensation at dorsal of her left hand, and could not extend wrist and fingers. And this is an X-ray that the day she come to see me. This is a post-op. She was operated with a narrow DCP, and you see it has a 2 screw in the distal fragment, and 1 screw enter in the fracture side, and she was pinned with a long arm slab.
And the renal palsy.
And the renal palsy.
After the operation.
Before. I asked to her.
Yeah.
I asked to her decreased sensation and weakness come before surgery or not. She said it happened before surgery. The diagnosis is a closed fracture, distal 1/3 of left distal humerus, and renal palsy. What next? I think the issue is we face unstable fracture and renal palsy. And I talked to her what the plan with to see or revision. That I concerned about the condition of the radial nerve because I don't have the intraoperative finding is injury or not, and we know that generally it is a neuroplasia, and I decide to wait for recovery of the radial nerve. These are 6 weeks post-operative. We still not see the callus formation, and the fracture line come to varus. But we're lucky, the radial nerve was recovered. Okay. And this is 3 months post-op. We still see no callus formation. And I talked to her again, and now she decided to operate. The issue that we should think about is if we decide to revision what the surgical approach and what implants and bone graft. Now I think it's come to delay union of the distal humerus and recovery of the radial nerve. I decided to revision and bone graft. The old surgical scar is on the lateral, and we prepare for autogenous iliac crest bone graft. I decided to approach in the same surgical scar. I go in the anterolateral approach, remove the plate and realignment and fix with a reverse LCP fashion and put a bone graft in. This is an immediate postoperative. This is 3 months after second post-op, we see the callus comes. And this is a function after 3 months. She can do full flex and extend the elbow. This is a issue that I learned from this case. One is, if you want to good outcome, we should good planning. Surgical approach, we must restore functional alignment, stable fixation to get early range of motion. And if it has a non-union, we should identify the cause of non-union. That, in this case, I think is come from the mechanics. And we should think about autogenous bone graft. Thank you.
So we start from, I think, from the youngest one.
No.
Okay, what is the point for this case? What we should have done?
So I think the problem of this, the problem in this patient is delay union with probably risk of failure of fixation since the beginning, and of course the radial nerve injury. So the objective is to get the fracture united in a good anatomy and function. And then we need to think about the nerve injury too. So if there is no any progression of healing, so I do agree to revise it, to treat it. So for the approach, it depends on the previous surgical approach too. So the objective is to remove the previous implant if it needed, and to explore the nerve, and then to get another fixation. So if there is just only one approach that can serve or can achieve all of the objective, it would be good. For in this patient, I do agree that I'm gonna do the same position, go to explore the radial nerve, and then remove the implant and then just fix it. So it's hard to fix on the posterior by this approach. So I do agree that I'm gonna go to the anterior plating like this. So you have maybe one choice of another straight locking, or just use modification like this, because you can get more number of the distal screw fixation. Okay, and bone grafting is another good option to augment in terms of bone support and bone healing. And for the radial nerve, it's probably injured at the first time of the injury, or probably further injury by the previous operation as well. So we don't know what's the major cause, but anyway, we need to explore and then solve the problem. And sometimes the nerve probably be entrapped with the previous implant. In such condition, we probably need to use probably like nerve graft or something that we need to prepare ahead of time. We have to discuss with the patient ahead and then prepare by using like sural nerve graft or whatever. You have to prepare it. That's my comment.
Okay.
Thank you.
Just ask the audience. If you see this patient 2 weeks with this type of fixation, and the patient, I think she still has pain, who will wait and see? Who will wait and see? Like the presenters, he wait and see. Nobody. One, only one. Please. Real life, real situation. เอาจริงๆนะเฮ้ย อย่าโกหก Okay, more and more, huh? Okay, now I trust you. Okay, I think I will ask Ajahn Suthorn. He teach me this kind of problems. I know he will answer. What he will answer?
As you said, in real life, most of us, if he doesn't see that implant break or everything pull out, usually they say wait and see, right? This is what my decision. I will as a fortune teller, do you think it's gonna stay or it's gonna fail when you have two screws on one side of the fixation, right? It will fail. It is a question of when. Either screw pull out, delay union. So what is the point to wait, right? But if this fixation is really good, you can check, in this case, because of the radial nerve, whether you wait and see, you do EMG, or you should explore. So I don't see the point in this case, because the fixation is so poor. It will definitely fail. What are you waiting for? You're waiting for to see that it's completely pulled out, so you waste another few months. So I think decision making is this. I think that's the point. I agree that most of us will wait and see, but if you ask me, I would look whether is there any chance to heal or is going to chance to fail. We must be a good fortune teller. If you have enough experience and you can tell what will happen in this case.
Yes, again, you see, 2 screws. Not only 2 screws, 1 circlage. I am the circlage man. I love the circlage. But I think in this case, you do open circlage and everything will, soft tissue will go away, right? So maybe this cause is both mechanical failures and biological failures. So I think, for me, I will not wait. And only 2 weeks is easy. You go in, you just cut the sutures, and then you go to the fractures. If you wait to 6 months now, it's a scarring. It's very, very difficult again. Right? So I think it's very many points to learn. Okay, Ajahn Sithiporn.
If we wait another 1 week for nerve study, just 1 week, because a nerve study can be done on 3 weeks, right? Another 1 week, I do agree have to do right now because inadequate implant. So I will wait 1 week for EMG and then go